Let's take a brief look at the pricing transparency situation in emerging markets with a focus on India. Indian hospitals seem to be great market investments. As of the time of this recording, late 2024, the average revenue per operating bed of major hospital chains in India, like the Apollos, the Fortises, the Maxes, etc., hover around close to Indian rupees 50,000 per bed. The price earnings multiples is astonishingly high. For listed hospital stocks, they are upwards of 50x in the stock market. Also, hospital pricing in India, especially in private hospitals, seems to have risen almost 2.5 to 3x times inflation year on year for several years. And there is a glaring difference in the pricing of procedures in private and public hospitals. Despite the size of the country, 70% of the healthcare delivery still happens from the private sector, and it is still dominated by small mom and pop shops scattered around the country, and the large hospital networks, the national chains, the regional chains, or the large single specialty chains probably occupy, I would say between 150,000 to 200,000 beds of the over close to 1.5 odd million beds in the country. So it's still a cottage industry. Even in India, the Supreme Court took notice and in the year 2010 forced the government to enact what was called the Clinical Establishment Act. It wanted the government to force hospitals to list their price bands for all treatments and procedures. The motive behind the act was simple, the three key objectives. Number one, crack down on dubious healthcare clinics. Number two, regulate the country's clinical establishments by prescribing minimum standards of services that are provided. And number three, and equally importantly, tackle rising medical inflation. But as we saw what happened in the US, even in India, this Clinical Establishment Act has been mostly gathering dust, moribund, and nobody seems to care, at least not as yet. But there is a rising problem because hospital prices, as I said, have been rising more than 2x year on year for decades. For example, a recent survey in the city of Bangalore demonstrates how the cost of treatment in government and private hospitals in the city can vary. Hospitalization in private establishments can be between 5 to 20 times costlier for similar procedures and treatments than in public hospitals. The study also found that 1 day stay in the intensive care unit in a public hospital could be between Indian rupees 1,500 to 2,000, while a similar stay in a private hospital could be about 30,000. The cost of medical procedures in this study showed that between two healthcare providers, when they compared the open heart surgery in a private hospital, the ranges can be between 2 to 3 times in terms of difference. And the same kind of variation was found in knee replacement, and it was the most disparate when it came to cancer treatments. Naturally, the Supreme Court pulled up the government, asked them to look at this act called the Clinical Establishment Act and consider introducing price controls across hospitals in the country. To add to this, insurance companies and the insurance industry in general have already started to complain and lobby the government and the courts of the day about hospitals inflating rates. The Supreme Court has warned that it won't hesitate to enforce a drastic measure and get all private hospitals to run with the same rates specified in the Central Government Healthcare Scheme, also called the CGHS. Now, these are really low rates that cover the medical costs of central government employees and their dependent family members, and they can be between 50 to 70% lower than what the current prices and charges are in private hospitals. It will set the cat amongst the pigeons, because even today, with these inflated pricings, the EBITDA, EBITDA, the earnings before interest, tax, depreciation, and amortization, for most private and well-run profitable hospitals in the country is between 15 and 22%. Imagine the margin compression such a move will have on private hospitals and on their valuations in the stock market. It is going to be interesting to see how all of this unfolds in the coming months and years. And finally, the Economic Survey Report of the Government of India clearly states that a large proportion of deaths in India is a manifestation of poor quality of healthcare, and it reflects and is likely to reflect that the quality of treatment in the private sector is not significantly better than it is in the public sector, despite the pricing being 5 to 20 times higher. Private hospitals, whether in emerging markets or developed markets, are charging exorbitantly and are getting away with murder, as I said at the beginning of this section on pricing. And with that, I just want to end this section with some parting thoughts. Based on the research and the study, the ability to hopefully shop for healthcare, is there a possibility that we can develop a grid-based pricing model that takes into consideration age, comorbidities, standard, iterative, or experimental? We looked at this in the process knowledge spectrum, whether a treatment falls in the standard framework like diabetes or cardiovascular treatments where the knowledge is well understood, or in the iterative like, let's say, cancer, or in the experimental bucket like in lupus or Alzheimer's, etc. Also, if the patient is insured or uninsured. Is there a way in which we can take all of these variabilities into consideration and evolve a grid-based pricing model which might encourage hospitals to play ball when it comes to pricing transparency? Surely, a lot of room is available in the domain of hospital pricing and pricing transparency. With this, we've now covered costing and pricing. Let us now turn our attention to how payment models operate in healthcare systems, both payment models in vogue